Okay, we're ready to rock it here in Vegas, and we're going to talk about the latest stuff out there relative to pediatric advanced life support. Disclosures-wise, sadly, I have none. Again, as Richie said, I don't think anybody wants to hire me as their speaker, but let's talk about our objectives. We're going to discuss the change in algorithm and how it affects pediatrics, because in a practical sense, in the ED, I don't think it affects us very much, all right? And we'll get back to that. We'll recognize some of the new trends and talk about some of the controversies. And I think here's the kind of the quickie outline that we can talk about relative to what's happening. First of all, AHA recommendations and their management is really a science of change. And what they try to do is incorporate the latest literature, and they use it, not only the literature, but they also have developed a consensus process, which they use as part of their consensus and evaluation conference that occurs really about every 5 years. How about cuff versus uncuffed tubes? Pretty much the cuff has it, and I'll talk about when and why, and we've addressed that in other talks today. Post-resuscitation hypothermia, are we there yet? The answer is probably no, but we're getting there. Parental presence, and this is something that we deal with on a daily basis in the ED, bringing the parents in and what effects that has, and we'll talk about that. The length-based resuscitation tape, is it accurate? And we'll address that as well. ECMO, and we've talked briefly about that, but we'll mention that again. And then neonates, there's a few things that you need to know about the neonates. First of all, routine suctioning is really out. Caution with oxygen, and these are the kids that need to be cooled. Okay, brief overview, you got it. Now let's get the background behind all of those things I just brought up. All right, in October of 2010, the American Heart released its latest guidelines, and we're now in 2013. But just understand that this evaluation process is a huge effort that involves experts from all over the world. They had over 356 experts in 29 countries come in to a single location after doing a considerable amount of background work on a number of questions that are vital to the care of children in cardiac arrest or in shock. The key thing is that you get all this evidence, and really the top level of evidence is randomized trials. Having done a randomized trial in airway management, it is a huge amount of work, and not everything that we do can be studied in a randomized trial. It's not feasible, okay? So what they try to do is they take the best evidence that's available, and they take animal studies, they take human studies, and certainly cohort studies and randomized trials, and they put them together and they say, okay, what level of evidence do we have to support this? And then they basically use a consensus process to then decide what the guideline should be. So you can imagine that not every guideline is as good as another. As an example, if you have a randomized trial on something that shows benefit, then that's going to be a level 1 recommendation. All right? So just to give you an idea. So what's new in the guidelines? First of all, the CAB are starting chest compressions early on is vital, because we take way too much time trying to get IV access or airway management in the absence of doing chest compressions. And what does chest compressions do? It creates perfusion, okay? And we need perfusion of the coronary arteries and of the brain in order to maintain those vital functions. All right, the other thing that's out are pulse checks and all that, and certainly I encourage the lay public just to do chest compressions, chest compression only. If they're frightened, they don't feel comfortable how to organize breathing and doing chest compressions only is really the way to go. I'm not going to talk much about the lay public today, but I think that is a take-home point. AEDs and actually defibrillation doses have changed. Initially, it was like you cannot use an AED under 8 years of age. Now, as you shouldn't use an adult AED under 1 year of age. Now it's changed, and really, I'll get into that with you in a bit, but really you could use an AED at any age. And then finally, it's nice to know that there are resuscitation teams that are available in the hospital. And finally, they've added a fifth ring, which is post-cardiac care. We talked about that today and some of the issues. Once the patient is resuscitated, you don't stop treating them. Yay, return of spontaneous circulation, but there's more to it than that, and that is the fifth link in survival. Again, fifth link is the post-cardiac care. So just to go over what the links are, prevention, and many of you are involved in prevention, and that's very important. Early CPR, early chest compressions, prompt access to 911, so calling, and on a worldwide level, there are more and more countries all over the world are developing 911 systems or something like that, 122, some simple number to call. So we're seeing that expanding on a worldwide level. And then finally, rapid pediatric advanced life support, and then post-cardiac care. So the issue is, why was the sequence changed? Well, there's a number of reasons. So we went from ABC to CAB, understanding that in the neonate, it's ABCs because they're all asphyxial arrests at the time of delivery. Some of the issues were that the chest compressions, in order to maintain perfusions, chest compressions have to be started right away. And because the algorithms were complex, remember that I remember going to an evidence evaluation conference a few years ago, a number of years ago, it was the one just before this, and they were talking to me about discussing the whole idea of airway management and what have you. And I said, we really have to simplify our algorithms. I mean, the reason why nobody, the lay public, they don't want to initiate resuscitation is they learn about it and it's so complex they don't know what to do first. You know, you got to tip the head, you know, you can either do a tongue jaw thrust or what have you. And then you have to remember, in a neonate is 3-to-1, but if it's in a child it's 5-to-1, and if they're older, 8 years of age, and it's 15-to-2, and then, whoa, right? That's just way too complex. So I think the chest compression only is really good to help the lay public begin to do the resuscitation right away. Anyway, the provision of ventilation delays the initiation of chest compressions, and that can happen especially with multiple intubation attempts. And so you always want to initiate chest compressions, get your stuff together, and then initiate ventilatory support. The other thing that we found is that CPR is typically done poorly, is too slow or too shallow, and associated with excessive ventilations. We do know that excessive ventilations increases intrathoracic pressure, which is going to decrease the amount of blood going to your coronary arteries and lead to myocardial dysfunction, and there's all kinds of sequelae related to that, and I think that's really key. And I'm going to emphasize something very important, and then we're going to practice it at the very end, okay? You guys ready for that? That's important. All right, and I'll get back to that. Adults and children will suffer VFib arrest. About 9% of children suffer VFib arrest, so it is important still to consider early defibrillation. Let's play our first case.
August 4th, 2011. The time is 3:11 a.m. and 03 seconds.
Harbor Base.
Hi, Harbor. This is Rescue 264 with a pediatric full arrest.
Go ahead, 264.
I've got a 2-year-old female. I don't have a Broswell right now. We're getting it right now. Full arrest. Found on scene. Downtime approximately 5 minutes. We've got a yellow 14 on the Broswell. Downtime approximately 5 minutes. Patient's parents state that the patient's been having asthma attacks all this evening, refractory to her albuterol treatment. Right prior to our arrival, they stated that she had what looked like seizure, tonic-clonic seizure activity lasting approximately 1 minute, and then the patient stopped breathing. We're attempting to establish an IV right now. We have CPR in progress, BBM with an OPA, and we're going to be our nearest PMC with our nearest facility with an ETA of approximately 5 minutes. How do you copy? She's got only history of asthma. Albuterol is her medication and no known allergies.
I copy that. So do we have a rhythm on this patient at this time?
She's got Stand by one, I'll get you one right now. Only an asystole.
Okay. About 80% of children are going to present in asystole. The number one cause of cardiopulmonary arrest in young children at this age is going to be respiratory causes. So this case highlights literally what you're often going to see. It's either going to be SIDS early on, although we're seeing less and less SIDS because of Back to Sleep campaign, but what you'll see is something just like this. And really the key thing in this algorithm, there on the left side, or let's see, on your left side, yeah, okay, is, your right side is going to be VFib, VTAC, and on the left side is going to be the PEA asystole algorithm. What do? Position the head, open the airway, begin bag mask ventilation as somebody is doing chest compressions. This is going to happen simultaneously, probably in the ED. You're going to try to get IV access. If you try a couple times, you don't get it, I would just put an IO in and go with that. The drug of choice in asystole that you're going to deliver is going to be epinephrine, and that's the 1 to 10,000 solution. High-dose epinephrine has never been shown to improve outcome. So the bottom line here is it's going to be airway management, good chest compressions, and epinephrine. And then think about some of the other causes. Certainly with PEA, we think about the H's and T's, and the most common are going to be hypoxia and hypovolemia. All the other ones are very uncommon in the pediatric age group. It's certainly something to consider depending upon what the scenario was prior to the arrest, but it's just important to know that the number one cause of PEA arrest is hypoxia or hypovolemia in the pediatric age group. You'll see tamponade or tension pneumothorax. That can occur later on, and so if you have a child who's been resuscitated that now decompensates after receiving positive pressure ventilation, then certainly you're going to think about a tension pneumothorax. Well, given that the American Heart came out with these guidelines and said, we really need to shift from ABC to CAB, even in the pediatric population, this was a study that was done in Japan and was published in Lancet of over 5,000 children in Japan, 17 years of age or younger. And it was a prospective observational study, and some of them received conventional CPR, which is airway management first, and others compression only. The conventional CPR improved neurologic outcomes if the cardiac arrest was non-cardiac in origin, and you can see the odds ratio there. And then for cardiopulmonary arrest of cardiac origin, there was no difference in outcome by type of bystander CPR. So none of this was out of hospital, and it kind of brought up the idea that maybe having some ventilatory support is going to be important in those non-primary cardiac arrests, and those are generally in the younger person. I still think that from a layperson perspective, and to be able to do appropriate chest compressions and the complexity of it, that probably CAB is okay. In the ED, we naturally are moving to a combined response in which ventilation and chest compressions are going to be equally as important. Okay. The other thing is no serious harm comes to the patient. We used to say, you can break the ribs and all that. Usually I see that in older patients, with more fragile ribs. Young patients, really, they haven't mineralized or calcified their ribs, and they have very flexible ribs. It takes great force to break the ribs of a child, so I wouldn't worry about that. And I think that's important. Now, in terms of where you put your fingers when you're doing chest compressions, this just demonstrates there's 2 fingers right at the nipple line, and I think that's a reasonable way to go, especially if it's one rescuer. So you can do chest compressions and then do either mouth-to-mouth or bag mask ventilation. When you have 2 rescuers involved, probably around the chest approach with the thumbs between the nipple lines are really going to be key. All right? The other thing is this probably gets better depth. The biggest problem that I see in rescuers doing chest compressions in children is they do something called leaning. They'll lean in, but they don't allow for full recoil. Because it's so easy to compress, they just keep compressing without allowing for full recoil. So very important, compress, recoil, compress, recoil. Okay, so you're going to compress and allow your fingers just to come up so that there's no tension on the skin line. Okay, really key for appropriate chest compressions in children. Healthcare providers, if you're alone, in order to make it simple, they made it everybody 30 to 2. Otherwise, for children, understanding that ventilation is very important, the ratio is 15 to 2. So we really have those two basic things to remember. If there's one rescuer, it's 30 to 2. Two rescuers is 15 to 2. Pushing hard and fast is the rule, and you want to go at least 100 a minute, and I think that's important in order to gain good perfusion. Here's the big thing, big change. Look at the ventilation rates. Breaths, 8 to 10 per minute. You want to avoid excessive ventilation. When we did the randomized trial of bag mask and ET in the out-of-hospital setting, and we're trying to come up with guidelines, I realized that everybody was overventilated. We used to bag people at our own personal pulse rate, right? So you're just, you're going as fast as you can. We thought the faster you bag, the better you bag. Well, that's not the case. Really, you want to squeeze the bag just until chest rise is initiated, and then release. So you're going to say squeeze, release, release. Okay, ready? Squeeze, release, release. A little louder, you can do better than that. Squeeze, release, release. Now, when you're bagging a kid, I want you to say that. Squeeze, release, release, and help your respiratory therapist do that as well. That's going to slow down the ventilation rate, prevent excessive ventilation, prevent too much air going into the esophagus and causing gastric distension. Okay? So if there's one take-home from this, it's going to be early chest compressions, and secondly, squeeze, release, release. Okay? The other thing they realized is that nobody can do this for very long. They get tired. So even in babies, you want to switch out every 2 minutes who's doing chest compressions. The pulse check, okay, it's totally out for the lay provider because we know they can't do it. It's just too challenging and too difficult, especially in these really critical patients. For us, you got 10 seconds. If you don't feel a pulse, you just start CPR. You start chest compressions, okay? No more feeling around, wait, I think I got it. No, I'm going to go down here, and They found there were delays somewhere between 24 seconds and even minutes to the initiation of chest compressions because of pulse checks. I mentioned AEDs to you. All right. The AED, or automated external defibrillators, are made for adults. There are pediatric modules or pediatric attenuators. Okay? That would be the best. Under one, to have a pediatric attenuator under one. The other thing is probably front to back. There's been some new literature that shows front to back placement is probably the best in children, one pad in the front and one pad in the back. If you don't have it, if you don't have the pediatric attenuator, you can still use the adult ones even on children under 1. All right, let's move on to pediatric advanced life support stuff. Cricoid pressure, I mentioned this before. I have found in my I was so thankful, okay, when the American Heart came out with this, because cricoid pressure to me is problematic. What happens with children is because they have their tracheas are not calcified, yet they have very flexible tracheas. Literally, I've seen a kid with hydrocephalus lean his head forward and go into respiratory arrest just because of kinking. So cricoid pressure is the same idea. We used to give cricoid pressure on everybody, and then you have a difficult time bagging and you wonder why. The bottom line is routine cricoid pressure to prevent aspiration during endotracheal intubation is not recommended in children, and it's more likely to cause problems than assist. That has been my experience. I don't use it. A common sense thing, a common sense plan is if anybody does give you cricoid pressure, you're having any problem, have them release it. Okay? It does not prevent aspiration either. How about bag mask versus ET? In the out-of-hospital setting, we know in a large randomized trial for which I was the principal investigator, we looked at this over 2 3/4 years in LA and Orange County, and it was so striking to me that there was no difference in survival between the groups, and indeed there were potential mortal complications in the ET group, such as esophageal intubation or dislodgement. So the recommendation now in 2010 and other studies subsequent to our study has also shown this to be true, that the recommendation is bag mask ventilation in the out-of-hospital setting over ET. In the in-hospital setting, endotracheal intubation is still the gold standard. However, please learn bag mask ventilation. Remember, squeeze, release, release. That's going to help you. Here's the key thing. We used to get kids in transfer and post-arrest that had been resuscitated, and they were being hyperventilated. And they were being hyperventilated. We'd get their blood gas, and they'd have a PCO2 of 12, and we're going, oh my God, that's amazing hyperventilation. Unfortunately, what has been found out in a number of studies with patients looking at cerebral perfusion pressure is that especially in children, if you over-hyperventilate, because their vasculature is so good at clamping down under those circumstances, that you can actually compromise certain areas of the brain and, with blood flow. And if you have a compromised area anyway with increased swelling, and now you compromise the blood flow, that causes secondary brain injury. So the bottom line is do not excessively ventilate. After resuscitation or during resuscitation, you want to go no more than 10 a minute. And certainly for older children or for neonates, no more than 20 a minute is what's recommended. All right? So during CPR, 8 to 10 a minute for children. How many of you have seen people go about 30 or 40 times a minute? It should be everybody in the room. Okay? So this is a really big change, and I'm telling you, it is going to help your patients if you slow down the respirations. Nobody died of hypercapnia, okay? But people die of hypoxemia. And that can occur if you over-hyperventilate. Again, squeeze, release, release, right? So squeeze just until chest rise is initiated, and then say the release phase. Bottom line, don't bag too fast. Okay. Cuff tubes, I mentioned this before. Will cuff tubes cause pressure on cartilage leading to pressure necrosis? The answer is no. There's now been a number of studies looking at this, and really thousands of patients have been treated with cuff tubes. And again, here's the deal. Post-extubation subglottic stenosis is equal between those with cuffed and uncuffed tubes, but about 30% of the patients who get an uncuffed tube need to be reintubated, and with all that associated complication. What if you can't get it and they have swelling, yada, yada, right? So you want the right tube in at the right time. Anybody who has lung disease should get a cuff tube. Anybody. The only time sometimes to consider are those who don't have lung disease. So, but it's hard to identify those patients who are being intubated. So my suggestion to you is use cuff tubes. So again, American Heart had said cuff tubes may be preferred in certain circumstances, poor lung compliance, high airway resistance, or large glottic leak. That's obvious. You want to avoid the large glottic leak. We had one the other day. We put a 3.5 uncuffed, and we had to exchange it out on a kid who was really sick. So again, try to use cuff tubes. All right, how do you figure out the sizing? You can use the Broslow tape. For uncuffed, it's age over 4 plus 4. This is over 1. And that's for uncuffed. And you just use a half size smaller. I can't remember these formulas in a pinch, right? So the bottom line is use a Broslow tape, get a half size smaller, you're going to be fine. So I just say half size. Capnography is recommended to confirm ET placement and assess the, whoops, back me up here. Okay. Anyway, let's go back. All right, capnography, you could use the colorimetric devices. Those are going to be fine, but they have certain limitations. Really, the waveform capnography is probably the best, or digital capnography is going to be the best. So some way to confirm. You could use the esophageal detector devices. Those aren't as accurate. It has been studied in children 20 kilos or above. In younger kids, it may be a little bit problematic. But the bottom line is some way to confirm tube placement besides your assessment. Foreign body aspiration, what the differences are, the key thing is for infants, for anybody who's conscious, for infants it's back blows and chest thrusts. If for a child over 1, it's abdominal thrusts or the Heimlich maneuver essentially. If they're unconscious, you just start doing chest compressions, okay? And then look in the airway for the foreign body. That's BLS. ALS, you're going to open the mouth using your laryngoscope and use your McGill forceps. We did a survey of emergency departments across the United States. It was published in 2007 in Pediatrics, and we found that 17% of EDs do not have pediatric McGill forceps, okay? As a take-home from this, you know, Monday morning, what are you supposed to do when you go home? See if you have A, cuff tubes in your ED, and B, you have pediatric McGill forceps. That is going to improve care. Oxygen. Gosh, just when you thought that, you know, something could be sacred, you know, but oxygen isn't even sacred anymore. Here's the thing, with too much, after resuscitation, with too much oxygen tension in the brain, it pushes it towards the formation of free radicals. And that can cause neurologic injury in areas that are compromised. So the key thing is we always start out with 100%. I say do it. Start out with 100%, but then dial it down to keep a pulse ox of about 94% or more, okay? So instead of spending your entire resuscitation, you want to consider just dialing it down. In neonates, you can start with room air. If their SATs don't come up immediately, you can use blended oxygen. That's the new recommendations. How about the length-based resuscitation tape? It's not a perfect tool. It's going to underestimate children between 8 and 10, probably. Certainly we have a lot of children that are heavier or have higher BMIs, but it's in a pinch, it's the best thing you have, and it turns out that it's highly accurate. We looked at this, almost 600 patients that came in, and we did a Brazo measure. The paramedics did a Brazo measure. We actually weighed the children, and the paramedics are actually pretty accurate in doing that. They're rarely off more than 1 color zone, and they're generally off less than 0.1 kilo. So the bottom line is it's probably a pretty good tool. If you can get actual weight, you should use actual weight. All right, what are some other changes? The addition of procainamide as a possible therapy for refractory SVT. If you've done adenosine, you're not getting anywhere. By the way, you can double or triple, you know, the 0.1 adenosine, okay? If that doesn't work, then you need to go with either procainamide or amiodarone. So that's been added. How about epinephrine as a drug of choice? It still is. There are some concerns about epinephrine. There's not great data. I have a feeling we may get rid of epinephrine eventually, but the bottom line is it's still considered the drug of choice for both symptomatic bradycardia in children and in those with PEA asystolic arrest, as well as the first drug of choice to be given in VFib arrest. Atropine can be added for symptomatic bradycardia if they don't respond to epinephrine. What is the treatment of choice for symptomatic bradycardia in children? And the answer is oxygen. Thank you. Bagging them, adequate ventilation. That is the treatment for symptomatic bradycardia. That is the very first thing you should do. Position the head, open the airway, begin bag mask ventilation. Somebody gets a line, and then you consider giving epinephrine. Symptomatic bradycardia, #1 treatment is oxygen. How much time do I have? Anybody know? No. Okay. Whoops. The little timer's not going. How much?
Monday, July 4th, 2011. The time is 11:58 a.m. and 03 seconds.
What's the wave on that? So that
Okay.
Fiber squad 41.
Squad 41? Go ahead.
Good?
I'm ready. Go ahead, Squad 41.
Okay, P is in Paul, Y is in Yolanda.
390042. At the home of a 17-year-old male, approximately 130 pounds. Unconscious on scene in VTAC. Cardioverted him at 200 joules, and we have a sinus tach now on the monitor at 124. Then the blood pressure, 160/70 is the blood pressure. Stick of 176. We have an 18 gauge established in the left arm. He did fall while playing basketball about 10 minutes ago. There is no apparent trauma on the body. He has a full C-spine.
Okay, what happened with this kid is he was playing basketball with his dad. He had sudden collapse. His dad did the life-saving maneuver, which was CPR. They called 911. He was in VTAC. At that point, they thought he had pulses, so they cardioverted him, and he was able to be cardioverted. He was GCS of 111, came in, woke up that evening after being intubated, and then went for electrophysiologic studies and ultimately got an AICD. They think he has a channelopathy, although we're difficult in trying to identify it. But that was just a great, great case, and we've seen a number of these kids. So the issue is, what do you do with tachycardia? Certainly, if it's wide complex, you need to assume that is VTAC. VTAC is inherently rare in children, so the other consideration is going to be SVT with aberrancy. And so adenosine can be given in with wide complex tachycardia just to see if the patient responds. So I think it is a new change to see the addition of adenosine. One of the risks, though, if they have WPW with adenosine, is that it can put them into ventricular fibrillation. So I'd have some real caution there. For older children, the likelihood, children that are young, remember, really young children, SVT is almost always caused by a bypass tract. Older children over 2, it's much less likely. So with older kids, I really support that, giving adenosine. The younger kids, I would just move to cardioversion. In terms of symptomatic bradycardia, we already talked about that. It's going to be good oxygenation, ventilation. You're going to then go to epinephrine, and then ultimately to atropine as a potential. We went over this briefly, but I didn't go down the VFib sign. If their pulse is VTAC or VFib, it's pretty much the same, except for none of the shock. You're going to start chest compressions, go for about 90 seconds or so, and then go ahead and initiate the first shock. And here's the change. The acceptable amount of shock or defibrillation, we start with 2 joules per kilo, go immediately to 4, and you stay at 4 joules per kilo for subsequent defibrillations. However, we realize that this may not be enough for some of the kids. And another child I had in full arrest, we ended up defibrillating her at 10 joules per kilo. So I feel pretty strongly after seeing now a number of cases like this, I dial up very quickly. I go 2, 4, and if they don't respond to 4, I go right to 10. So it is a change, and it is also supported by the American Heart Association. You can go to higher energy levels. Here's our outcome, and unclear cause, but they definitely got he got an AICD. The other thing is kids with sudden cardiac arrest, they all need autopsies. So work with your One Legacy or your other people to consider encouraging families to get autopsies. Why is it important? Is because somewhere between 22 and 50% of first and second degree relatives have this inherited channelopathy. They may just have a little less predilection for it. My husband's partner, his daughter, had sudden arrest while swimming, and it turns out their family does have an inherited channelopathy. Okay, it's very important. She has an AICD. She's got a normal life. But if they tested the other family members, and that's really the key, because one of the other siblings had it and prevented that child from needing to go into arrest. Therapeutic hypothermia, the bottom line is, we mentioned this before, it's beneficial for neonates, but not necessarily the data is in for children. And finally, family presence. Numerous studies have documented that parents wish to be given the option of being present. Not all want to be present. I have found that families are very thankful if they are allowed to be present in the resuscitation room, even if the child expires, okay? Because they've known, they get the feeling that everything was done. It does not inhibit your ability to perform, okay, in front of parents, and it does not increase your medical legal risk. And then I'm going to skip children with special health care needs, and I think I'll end on these two things. One, for neonatal resuscitation, you maintain the ABC sequence, and there's a big de-emphasis on peripartum suctioning because that ends up causing hypoxic insults, okay? The only time we're going to consider really vigorously suctioning if there's signs of obstruction, airway obstruction, or ET suctioning for meconium-stained amniotic fluid, and the neonate is not vigorous, meaning poor tone, poor heart rate. Let me just skip ahead for a second. Finally, the neonates, if they're term, they're crying and breathing and have good tone, really, you dry stimulate, and the recommendation to keep their keep their temperature normal is placing them skin to skin on the mom and have the mom hold the baby. So really, that's the latest recommendation there. Let's see, one final thing that I should mention is the neonatal ventilation to compression ratio is 3 to 1. I know that makes us insane. It's basically 90 compressions and 30 ventilations on a 1 to 3 ratio. Because it's an asphyxial arrest, the neonatal group really felt they could not go beyond that recommendation to simplify it further. And then finally, CPAP could be used to bridge. I mentioned therapeutic hypothermia, and I've already mentioned about a resuscitation on room air. We found that the resuscitation on room air decreases the number of free radicals. I was going to talk about withholding, but I think I'll stop there in the interest of time because I think I've already gone beyond my limit. But I hope I've given you at least the highlights of what's out there and some of the new changes actually since the Evidence and Evaluation Conference. And thanks so much.